I have great pleasure in introducing Dr. Anju Grewal from Ludhiana, India. She is a professor of Department of Anesthesiology at Dayanand Medical College and Hospital, Ludhiana, Punjab. She is the chief editor of the Journal of Anesthesiology, Clinical Pharmacology since 2013. She is a founder member of Airway Management Foundation. Presenting to you, Dr. Anju Grewal.
Good afternoon, dear friends. It's indeed a pleasure and an honor to be part of this great academic extravaganza. And I would like to take this opportunity to thank wholeheartedly the great visionary and exemplary academician, Dr. Bala Venkat Subramaniam, and his dynamic team of GARC 2020 for inviting me to talk to you on failed airway in a parturient way forward. I bring you greetings from Dayanand Medical College and Hospital, Ludhiana, the place where I work. In the next 15 minutes, we'll look at the incidents and reasons of failed airway in parturients. With the help of available guidelines, look at if there is a way forward to prevent and reduce the harm if difficulties do arise. To look at the incidence of difficulties that we face during intubation or airway management in pregnant population, we find that they are 8 times more prevalent than the non-pregnant population. And despite the technological advancements and the spate of guidelines, the incidence of failed tracheal intubation in obstetric population has stayed unchanged since 1970. What does that tell us? Does it mean that pregnant patients are more vulnerable than their non-pregnant counterparts? We all are aware of the unique maternal, anatomical, and physiological changes that pregnancy imposes on the parturient, making them more predisposed to a higher risk of airway-related events in the form of either airway bleeding, edema, desaturation, aspiration. All of these get exacerbated in the presence of high-risk factors like advanced age, complex comorbidities, obesity, to name a few. These unique, clinical issues are further compounded or complicated by the situational and human factors that arise due to the unpredictable nature of labor, which, at times makes us face emergencies at the middle of the night that mandate administration of general anesthesia. And usually, these are problems which are faced by a novice or an inexperienced anesthetist who has limited exposure to general anesthetic administration in this group of population. And furthermore, they are confronted with conflicting needs of 2 lives, odd hours, time pressures, poor management, poor planning, and a gamut of human factors come into play, leading to poor outcomes. Given the unique clinical, situational, and human factors, combined with the vulnerable pregnant parturient who is more vulnerable for a difficult intubation or a difficult airway, are we not looking at a perfect recipe of failure lurking on us? Is there a way forward? Guidelines have actually shifted the focus from prevention of failed intubation or a failed airway to one of reduction of harm. And as we move towards measures of reduction of harm, it is pertinent that if at all we are faced with a scenario mandating administration of general anesthesia at an odd hour, it is pertinent not to jump into the well, but to take a step back and try to incorporate all the elements of safe obstetric general anesthesia. Foremost among them is assessment of airway. A timely, focused global airway assessment using a line of sight approach is extremely important and vital to safer airway management. It indeed forms the base or the kind of guides us towards kind of airway management that this mother would need. Indeed, when I talk about global airway assessment, it means that we not only look at difficulties in laryngoscopy and endotracheal intubation, but we also look at difficulties in bag mask ventilation, insertion of a supraglottic device, and also front of neck access, and inclusive of cooperation or uncooperation from the patient as well. It's a good idea that before we leave our routine theaters and go back home, walk into the labor floors and have a look and assess the airways, document them out so that the emergency team is not popped up with surprises and difficulties ahead of them. The second part of assessment focuses around looking at the aspiration risk that the mothers can pose to us, and hence knowing their fasting status, whether or not an aspiration profile Excel has been administered to them. And if you have a proficient person who can look at the gastric ultrasound to look at the gastric contents, it will be great to individualize the risk of aspiration and reduce the harm if it does occur at any point in time. Equally pertinent is to talk to your obstetric colleagues to understand the indication and urgency of cesarean section, discuss with them whether or not you would make a plan to either proceed with surgery or awaken the mother in case of a failed airway event. Having gathered this information, is now time to sit down together with your team for a briefing which helps us formulate the primary and the failed airway management strategy, including the extubation strategy, which is extremely important in these difficult airways. As you sit together for this briefing, you help make a roadmap, assign roles to all people, and therefore improve your team dynamics and get more teamwork coming into this, which is so vital for preventing a failure from occurring. Having made your plans, assessed your patient, it is now time to check availability of equipment that you need to execute these plans. And therefore, equipment for both the primary plan, the difficult airway, the rescue plans, and the failed airway are all to be there. It's a good idea to have a difficult airway cart, which is well labeled, well stacked, and also checked at regular intervals on a daily basis with equipment which you all are familiar to use with. Now is the time to move to optimizing your patient on the OR table. With the patient on the OR table, we now need to look at measures not only to prevent hypoxemia and aspiration, but we also need to look at measures which ensure that our first attempt is the best attempt. Optimal patient positioning with a 20 to 30 degree head up position and a ramp position which aligns the suprasternal notch with the external auditory meatus not only facilitates insertion of a laryngoscope, it also improves glottic view, increases the functional residual capacity, and reduces the risk of gastric regurgitation. Now, this optimal positioning, if combined with good pre-oxygenation, adequate pre-oxygenation, and also measures to ensure apneic oxygenation, something that some of us call as para-oxygenation, by putting in either a nasal cannula or a high flow nasal cannula, HNFC, which we are so well versed now using it thanks to our COVID times. Both a combination of both a tight fitting mask pre-oxygenation for 3 to 4 minutes of tidal breathing, or of 3 to 4 maximal capacity breaths combined with a nasal cannula or an HNFC cannula will not only prevent desaturation, but also improve and prolong our safe apnea times. Now, while you're pre-oxygenating, it's always a good habit, and indeed would recommend that we mark the cricothyroid membrane, preferably using an ultrasound machine if we have skills for that. The modified rapid sequence induction that you have decided to give to your mother necessitates two important modifications. One, that the doses of induction agent and neuromuscular blocker should be adequate, and bag mask ventilation should be allowed. Indeed, a gentle bag mask ventilation, allowing an insufflation pressures to less than 20 centimeters of water with a cricoid pressure, is something that will give us a hand-brain connection and assure us, the provider, that one has the ability to ventilate this mother in case of a crisis. Cricoid pressure is an important maneuver to prevent aspiration. However, we need to remember that there has to be a low threshold of letting it go, of releasing it in case you're facing problems. Also, if improperly applied, can at times lead to impediment of proper placement of an endotracheal tube as well. Endotracheal intubation should preferably be done either by a short-handled laryngoscope, but if you do have access to a video laryngoscope, it is a good idea to use a video laryngoscope, which you are so familiar with, because the use of video laryngoscope enhances your teamwork. Both you, your assistant, and the supervising anesthetist can look at the view, glottic view, and optimize things for us together. Majority of the guidelines, including the Indian guidelines, limit the number of intubation attempts to 2 before proceeding to the next step. And hence that makes it important that we have the best optimal attempts as the first 2 attempts that we are limited to. And if these 2 attempts at intubation fail to secure the airway, we need to declare failed intubation not only to our own team, but to the obstetrician and to the neonatologist as well. And now is the time to quickly move to optimized rescue techniques. We are focusing on, and a priority right now is oxygenation. At the same time, you need to look at or prevent aspiration and awareness, which so happens commonly because we are so bogged down by this and kind of scenario that we have landed up ourselves into. The best first rescue device is a second generation supraglottic device, which not only provides you a gastric drain channel, but also allows higher inflation pressures. You need to optimize its placement, and therefore removing the cricoid pressure during its insertion is mandated, and then you can reapply later once a successful insertion has occurred. It has been shown in various studies that cricoid pressure application impedes the proper adequate placement of a supraglottic device and hence should be removed. You are only allowed 2 attempts for a supraglottic device insertion, and you need to watch your SpO2 values. Saturation of 75% and above is what should be there on your monitor for these pregnant mothers. A value below it mandates escalation of your efforts to ensure oxygenation. You may try a single attempt at a bag mask ventilation using a 2-person face mask technique if your attempt initially, when you were doing the first rapid sequence induction, it was optimal at that point in time. However, if you are unable to oxygenate your mother by these 2 attempts, it is time to again quickly move on and announce the final rescue for a cannot intubate, cannot oxygenate situation or a ventilation failure scenario, and wherein it is advisable to move on to scalpel cricothyroidotomy, a technique which provides you a definitive airway and is also easier. Would have been more easier had you marked the cricothyroid membrane prior to induction, and that is why we were so keen to mark it up there, especially in obese parturients. It's pertinent that during all rescue maneuvers, we ensure good neuromuscular blockade because that will ensure that laryngospasm and poor chest wall compliance are not factors hindering oxygenation. In a scenario where you're unable to restore oxygenation despite a front of neck access, you need to remember that cardiac arrest is going to be imminent and hence a high quality ACLS and a perimortem cesarean delivery will have to be soon transitioned into, and the team should be ready for such an eventuality. However, we do hope that with all these optimal measures, oxygenation would be restored by our rescue measures, especially by a supraglottic device. And then you're faced with a dilemma of a decision to make whether to awaken your patient or to proceed with surgery. Though a roadmap would have been decided before you induce this patient, this decision at this point in time will depend upon the judgment of the team of anesthetists and the obstetricians, because this is a constantly evolving situation, and you will also have to take into consideration the skills that the team have and the confidence that you have in your skills. You can take the help of the decision aid, the guidelines provide us to consider factors that will help us decide whether we should awaken our mother or proceed in this dynamic, evolving situation. What you need to remember here is that irreversible causes like major placental abruption or fetal hemorrhage, or any situation that causes a maternal compromise which is not responsive to resuscitation, mandates that you proceed with surgery with the rescue device that you have used to restore oxygenation. Whether you decide to wake up the mother or proceed with the surgery, at all times of transition or decisions, you need to maintain oxygenation, ventilation in a head-up position, avoid awareness and aspiration, and remember that CICO or a laryngospasm can occur at any point in time. You need to resist the temptation by looking at the risk-benefit ratio of putting an endotracheal tube through the supraglottic device that we have inserted. If that has to be done, especially in a case where we proceeded with surgery, should be attempted in a well-planned manner after the delivery of baby. And also the fundal pressure that is being used by the obstetrician to deliver the baby should either be minimized or avoided altogether. So where does that bring us at the end? It's time for all of us for paradigm shifts from one of prevention of a failed airway to the one of harm reduction and a focus on oxygenation. We need to move away from a holy grail, the endotracheal tube. We need to understand that a decision to try again a second time should be based on the information that you've received in the first best attempt. Always remember in your heads that waking up a parturient in a real life scenario is indeed many a times not a real choice. It's very, very difficult to engineer a smooth, well-oxygenated emergence under that dynamic conditions. And therefore, we all need to think about transitioning to second generation laryngeal mask airways, which also allow a good conduit for an endotracheal tube early on in airway management. And this is an area which still needs a lot of research for safety protocols in these special group of patients. With the kind of cognitive load and the emotional load that you have, there are huge amount of chances that we might, miss up a step or forget things going around us or get overwhelmed there. And therefore, adopting or using cognitive tools like the vortex tools not only helps us in decision making, but also helps in teamwork in real time. And so the best way forward, I would say, for a failed airway is to preempt a failed airway from happening or reducing the harm. And we need to introduce into our workplaces this best way or this concept of airway team, which not only plans but prepares, briefs, debriefs, and also trains together. This is what a combination of all these interventions is going to make your craftsman better along with his skills. You need to practice and re-practice with the same team to ensure that maternal safety is there at all times. With these thoughts, I take this opportunity to invite you all for the Association of Obstetric Anesthesiologists National Webinar scheduled on 9th and 10th of January on a topic that is so dear to all of us so that we are able to save 2 lives. Thank you all for our patient hearing. God bless and stay safe.